Hi, my name is Kenneth Wang, and I'm senior author on this manuscript, Safety and Histologic Outcomes of Endoscopic Submucosal Dissection with a Novel Articulating Knife for Esophageal Neoplasia. And this will soon be published in GIE. I'd like to thank all of my co-authors, especially Dr. Juan Reyes-Jenner, for their assistance in this manuscript. Basically, we are trying to address the issue of adopting endoscopic submucosal dissection in Western countries. As many of you are aware, endoscopic submucosal dissection has become the de facto standard for large lesions in the esophagus in Asia. However, in the United States, endoscopic mucosal resection, usually using the band technique, is most commonly applied in the West. Now, there are several reasons for this problem, one of which is training. There just hasn't been that many programs, although this is slowly being resolved. The ASGE has a course that was started almost 5 years ago, thanks to our help with our sister societies, the Japanese Society of Gastrointestinal Endoscopy. However, there's also the problem of having the appropriate cases. In Japan and in Asia, most of the physicians begin their training with gastric lesions, which are easier, the approach is simpler, and there are quite abundance of them in Asia. However, in the West, as you know, we have very few esophageal gastric lesions, especially early ones, and we have much more colonic lesions, which are much more difficult to resect. Given that, we thought we would review our experience with a novel endoscopic submucosal dissection knife that uses an articulating scissors type device that's much more intuitive for endoscopists to use. It also has the advantage of being able to coagulate or cut using the same instrument. So this is what this article is primarily about, our experience with 72 endoscopic submucosal dissections versus an equivalent number of endoscopic mucosal resections that were done by myself and another co-author. All of the endoscopic submucosal dissections were done by myself. There were a total of 115 patients in this series. This included 54 patients who had 72 endoscopic submucosal dissections that were done, as compared to 52 patients who had 72 multiple endoscopic mucosal resections. Now, in both cases, the lesions had to be greater than 15 millimeters in size, and in the endoscopic mucosal resection case, since we know complications are related to the number of resections performed, we restricted this between more than 3 and less than 5, as complications rates would increase beyond 5 resections. Now, when we looked at the results, we were able to find out that most of the patients with either technique did very well. I won't go into details of the technique using multiple band resection, as you're probably all familiar with those, but using endoscopic submucosal dissection, especially with an articulating knife, we use slightly different settings than you're probably familiar with. Because the knife actually pinches the tissue between the two conducting arms of the knife, we're able to apply a fairly aggressive cutting current. And so we used effect 2 with a duration of 3 and an interval of 1 to be able to cauterize the tissue for dissection. That seemed to work fairly well. On the other hand, and that's using EndoCut Q. For coagulation, we use soft coagulation mode, and there we used effect 2 at 80 watts. For injection, with the EMR, this was usually just done with a 1 to 200,000 dilute epinephrine solution. It might or might not include methylene blue depending on the day. Usually with multiple resections, we tended to include that. With the endoscopic submucosal dissection, we usually used hydroxypropylmethylcellulose, or GONAC, and we use this at a concentration of 15%. We also mix this in 1 to 200,000 epinephrine and methylene blue, which causes a good lift that will stay up for sufficient time for endoscopic submucosal dissection. Overall, like I mentioned, we had good results. There was only 2 complications. Both occurred in the endoscopic submucosal dissection group that led to a complication rate of 3% versus 0 in the multiple endoscopic mucosal resection group that was matched according to age, gender, lesion size, and Barrett's length. We were able to upstage the initial biopsy results in the endoscopic submucosal dissection group by 27%, whereas this was only upstaged by 12% in those patients that underwent endoscopic mucosal resection using the band technique. Now, there could be some debate of how real this finding is, but we did take great pains to ensure that the overall area of resection was similar between the ESD group and the EMR group. So it shouldn't just be on the basis of increased tissue. I believe that because you can take out an en bloc resection, as the Japanese have already shown, this decreases the recurrence rate of any neoplasia. But I believe it also increases the accuracy of the upstaging, as you're not looking at all these cauterized margins from multiple EMRs that can confuse the pathologist. Instead, you're giving them a large en bloc resection. So I think this is truly a benefit. In summary, we believe that endoscopic submucosal dissection is a safe technique, as safe as doing multiple endoscopic mucosal resections, and probably gives you better histological evaluation in terms of upstaging the disease, as well as probably depth of penetration. I really like to thank the editors of GIE for this opportunity, and I hope that you have enjoyed this presentation and you will go on to read the article. Thank you.